I'm so pleased to welcome you to the inaugural NINR Early-Stage Investigator Lecture series, Advancing Systems to Optimize Care. We're glad that you're here to share with us in an important moment for the Institute. At NINR, we see early-stage investigators not simply as the future of our field, but as the scientists who are actively shaping the field now. This series was created to provide a platform that elevates the visibility of our emerging investigators, highlighting their bold work that they are leading and reinforcing our commitment to supporting their success. The work we will feature in this series is grounded in strong science, but equally important, it is designed to inform practice, to improve how care is delivered and experienced, while also taking into consideration the real-world settings in which this evidence practice is applied. That's core to how we think about nursing science, generating evidence that's actionable, that can be implemented, and that ultimately helps us understand what works, for whom, and in what settings. Today's lecture is the first in what we intend to be an ongoing effort to create space for our early-stage investigators to give voice to this work. In just a few moments, you will hear from Dr. Muir from the University of Pennsylvania School of Nursing. Her work focuses on identifying models of care that improve access and timeliness in community-facing settings, exactly the type of work that reflects both rigor and real-world relevance. She will be joined by Professor Dr. Gonzalez-Guarda from Duke University, who will serve as the discussant. Together, they represent the kind of thoughtful, impactful scholarship that this series has been designated to elevate. Next slide, please. Before we get started, I want to take just a quick few housekeeping notes to share with you. Today's lecture is being recorded and will be made available on the NINR website. Closed captioning is also available, and you can enable that at the top of your screen. We encourage you to use the Q&A function throughout the session to submit questions. We will hold those until the end, and we'll get to as many as time allows. We're also pleased to offer continuing education credits for today's webinar. Details will be shared at the end, including a QR code for the evaluation that is required to receive credit. Next slide, please. We are especially pleased to launch this series during National Nurses Week. This year's theme, The Power of Nurses, is an important one that reflects the essential role that nurses play in delivering care, but also in the leadership that nurses bring to advancing science and improving the outcomes across settings. Every day, nurses are at the forefront of care, but what is sometimes less visible, yet equally critical if you ask me, is the science that informs that care. Nursing science plays a distinct role in the broader research landscape. It is grounded in the realities of care delivery and focused on generating knowledge that is both rigorous and usable. It brings together clinical insight with an understanding of environments in which people live and receive care, and translates that into solutions that can be implemented and scaled in conditions that are beyond the walls of the hospital or the clinic. This is where early-stage investigators are making a meaningful contribution. They are asking important questions, developing innovative approaches, and advancing work that is responsive to the complexity of real-world care. At NINR, we are committed to supporting that work, particularly research that is solutions-oriented, that addresses the conditions that shape health, and that produces evidence that can be put into practice. This lecture series is one of our ways of doing that. Again, it is designed to elevate our emerging investigators, to highlight the impact of their work, and to signal clearly that their contributions are central to advancing nursing science. Next slide, please. And it is a pleasure of mine that in that same spirit of partnership and shared commitment to the field, we are honored to be joined today by Dr. Jennifer Menzek-Kennedy, President of the American Nurses Association. Dr. Kennedy is a nationally recognized leader who has been a strong advocate for nursing workforce and for advancing professional practice. Her work is focused on leadership, workforce innovation, and strengthening the role of nurses in the healthcare system. We are so grateful for her partnership and for the role that the American Nurses Association plays in elevating the contributions of nurses nationwide. So please join me in welcoming Dr. Menzek-Kennedy, who will introduce today's speakers.
Good afternoon, and thank you, Dr. Eklund, for that generous introduction, and thank you all for being here. For more than 4 decades, the National Institute of Nursing Research has helped set the direction for nursing science in this country. NINR has consistently asked the hard questions, supported bold inquiry, and generated knowledge that improves health, strengthens systems, and makes care work better for people who rely on it. The impact is felt every day in communities and clinics and at the bedside. So it's especially meaningful to be here during National Nurses Week, as we celebrate the power of nurses, and to join you for the inaugural Early Stage Investigators Lecture Series. I am honored to introduce today's speakers, Dr. Muir and Dr. Rosa Gonzalez-Guarda, who will be leading today's discussion with Dr. Muir. Dr. Muir's work speaks directly to several of the challenges we're wrestling with across healthcare right now. Her research examines nursing models of care that improve access and timeliness in community-facing settings, places where nurses often do their most important and least visible work. Far too long, our systems have concentrated resources, people, funding, attention on acute care after illness has already escalated to crisis. When pressure builds, we respond by asking nurses to do more with the same structure. That approach has real limits, and nurses know better than anyone. What I appreciate about Dr. Muir's research is that it doesn't just critique what's broken, but it offers evidence-based alternatives using both qualitative and quantitative methods. She evaluates models that make better use of nursing expertise to improve outcomes and use resources more wisely. She also explores how nurses' work environments shape what happened to patients, because how we design care systems directly affects what the care the patients receive. Dr. Muir joins us from the University of Pennsylvania, where she is an assistant professor of nursing at the Center for Health Outcomes and Policy Research. She also holds a secondary appointment in emergency medicine at Perelman School of Medicine and is a senior fellow at the Leonard Davis Institute of Health Economics. Her research is grounded in practice as a family nurse practitioner at the Puentes de Salud in Philadelphia, supporting patients as they transition from emergency care into primary care, a perspective that shows up clearly in her scholarship. Since earning her PhD from the University of Virginia in 2021, Dr. Muir has co-authored nearly 40 research papers. Her work has examined readmission disparities among patients with limited English proficiency, nurse staffing, and departures against medical device, chronic wound management, and mortality among patients with dementia. She also holds an MS in health policy research from Penn and an MS and BSN degrees from the University of Virginia. We are honored to hear from her today. Joining her in the conversation is Dr. Rosa Gonzalez-Guarda, a nationally recognized leader whose work has advanced health equity, community engagement, and justice-centered nursing science. As a professor at Duke's University School of Nursing, Dr. Gonzalez-Guarda focuses on improving health outcomes for Latino and other historically marginalized communities, particularly those affected by stress, trauma, and adversity. Her research spans violence prevention, substance use, HIV and other STIs, and mental health, with a strong emphasis on developing, testing, and scaling interventions that work in the real-world settings. She has authored and co-authored more than 100 peer-reviewed publications and has served as a principal investigator or key contributor on multiple grants from NINR, NIH, and the National Institute on Aging, and the National Institute on Minority Health and Health Disparities. In her role as co-chair as the Community Health Improvement Core of the NIH Pragmatic Trials Collaborative, Dr. Gonzalez-Guarda is helping to reimagine how clinical research is done, expanding participation by underrepresented communities, and ensuring that trials reflect the realities of everyday care, not just ideal conditions. She is also alum of the American Nurses Association Minority Fellowship Program and holds a PhD from the University of Miami, a master's degree in nursing and public health from Johns Hopkins University, and a BSN from Georgetown University. I am very much looking forward to the conversation between Dr. Gonzalez-Guarda and Dr. Muir, and to the insights it will offer about the future of nursing research, practice, and policy. Please join me in welcoming Dr. Jane Muir and Dr. Rosa Gonzalez-Guarda. Dr. Muir.
Thank you so much, Dr. Mensa Kennedy, for that very kind introduction. Hello, everyone. I'm Jane Muir. I'm from the University of Pennsylvania School of Nursing, and I'm so excited to be here today. I want to first start by thanking the National Institute of Nursing Research for the opportunity to present the inaugural NINR Early-Stage Investigator Series lecture. Today, I'll be presenting on my research program and NINR-funded work focused on advancing systems to optimize care. Happy National Nurses Week to all the nurses who are the bedrock of our healthcare system. I have no conflicts of interest, and the research discussed today is funded by the National Institute of Nursing Research through a Career Development Award. I'm an assistant professor at the University of Pennsylvania School of Nursing, and I'm core faculty in the Center for Health Outcomes and Policy Research. I have a secondary appointment in the Department of Emergency Medicine at Penn Medicine, and I'm a senior fellow in the Leonard Davis Institute of Health Economics. I earned my PhD in nursing from the University of Virginia, then went on to do a postdoc in the National Clinician Scholars Program at Penn, where I was also an NINR T32 fellow in the Center for Health Outcomes and Policy Research. My research focuses on generating evidence that improves the timeliness and quality of patient care in community-facing settings, including community health clinics and emergency departments. And the focus of the work I'll be discussing today is on emergency department care related to my Career Development Award. So I'm an emergency department nurse by background, and that very much influences the research that I do. And when you clock into a given shift in this setting, like on other units and in other settings, everyone rounds up for a huddle, usually given by a charge nurse. And huddle is where you learn about the system you will be operating within for that day as a nurse. This is where you're going to get a sense of whether or not your day will be sufficiently staffed of nurses or other staff that you're working with. And this is something you can really pick up just by looking around in the huddle that day. Whether you'll be able to do all the tasks for your patients or just the bare minimum, whether you'll be able to take a bathroom break or a lunch break, whether there's going to be a nurse practitioner working on the shift with you who can triage primary care patients who are coming into the emergency department, whether you'll be able to clear the waiting room of patients, whether you can call an in-person interpreter for ideally the best interpreting services for a patient, or whether you'll have to use a Seracom or video or audio interpreter. My point is that the systems nurses operate within influence outcomes for patients and nurses. And because of historic funding from the National Institute of Nursing Research, we know a lot about nursing resources, including how nurse staffing is organized or invested in, the quality of the nurse work environment, the composition of nursing skill mix in hospitals, and educational levels of nurses, and how these systems of nursing care influence the inpatient side of hospitals and their impacts on patient outcomes, like survival after in-hospital cardiac arrest, 30-day mortality, patient length of stay, hospital readmissions. But what hasn't been studied so much is how 70% of patients enter hospitals through emergency departments, yet how nursing care is configured here to optimize patient outcomes is less understood. And emergency departments are important care areas. They are the initial point of entry into hospitals, and they're the most community-facing aspect of hospitals. And from a clinical standpoint, nurses here are critical to the early identification of important diagnoses like sepsis and the assessment of certain conditions of daily living that we know affect patient outcomes, like the availability and quality of transportation, food, health literacy, language access services, security and safety at home, and other factors that influence patient outcomes. Emergency department care is challenging, though, and there are unique constraints about this environment that have historically made it hard to study this area, and then issues that arise in this setting go on to be unaddressed. These are things like hospital crowding or emergency department crowding, which is when high volumes of patients enter hospitals through emergency departments, but they can't be seen quickly. So they back up in the emergency department through waiting rooms, they receive care in hallway beds. This can lead to poor patient outcomes, outcome disparities, and unfortunately, nurses are on this receiving end of a lot of workplace violence in this area. A common narrative around this reality is, well, this is just how it is. What do you expect? It's an emergency department. Well, that's not a satisfactory statement for me, and my work is actively pushing back against this assumption that we can't improve the system of emergency department care. We need to improve care in this setting if we want to make care more timely and accessible to individuals in our community, because hospitals are important touch points, and especially emergency departments are important touch points for communities. They're accessible 24/7, and they're open to all patients regardless of background and characteristics. And nurses are crucial in this setting. They are at the point of care well positioned to stabilize acute illness and identify social needs that need to be addressed either in a visit or connect patients to outpatient settings or transitional care programs. They are often able to work in small pockets of time in this setting to connect patients to safety and to high quality patient outcomes. So my work focuses on optimizing emergency department patient outcomes by leveraging the systems emergency department nurses operate within. And although many interventions have been trialed to make care in this setting more accessible and high quality, few have focused on nurses as the largest clinician group overseeing the majority of patient care stabilization and throughput in this area. My work funded by NINR focuses on how to leverage nurses to study problems in this area that have continued to go unaddressed and threaten how accessible healthcare is in hospitals. So I want to start with two studies that I worked on in my NINR funded T32 that have been a foundation for my work in studying the ED within a system. The first study identified that the inpatient nurse work environment affects emergency department nurse job outcomes. And favorable compared to less favorable nurse work environments, emergency department nurses experience 52% lower odds of burnout, lower odds of job dissatisfaction, and lower odds of intent to leave. So this really implies that the quality, even though emergency department nurses don't work in the inpatient setting, that inpatient system has a downstream effect on the ED nurses' experience. And this work was cited in the Emergency Nurses Association position statement on nurse staffing and productivity in the emergency department in 2025. Through a separate study, I also identified that the inpatient nurse work environment affects emergency department patient wait times. In favorable nurse work environments compared to less favorable, emergency department length of stay was reduced by 13 minutes, behavioral health patient length of stay by 33 minutes, and there was a reduction in the proportion of patients who left the waiting room before being seen. Now, you may be wondering, like, how much does 13 minutes really help in a care encounter? Well, anyone who works in the ED setting knows we have a phrase that's time is brain, time is heart, meaning any time that we can save to move a patient on to the next step, to get them discharged, to get them admitted, gives us back more time to assess the next patient, make sure someone in the waiting room is not deteriorating, make sure that we can call the necessary specialty visit to stabilize a patient's care. And so that time is really crucial in this setting. This work thus far that I've shared emphasizes that to improve emergency department outcomes, we have to examine the broader system the emergency department operates within. It's not just about the ED, but also the inpatient setting and the broader hospital context. The ED is unique in that the inpatient setting and even the community aspects in the community influence the ED in ways that the ED doesn't necessarily influence the inpatient setting. And that's what I wanted to unpack a little bit further in my Career Development Award. I'm fortunate to be mentored by a fantastic interdisciplinary team of faculty at the University of Pennsylvania on my K01 Career Development Award. Dr. Margot Books-Carthon from Penn Nursing is my primary mentor, and my secondary mentors are Dr. Ken Cato from CHOP and Penn Nursing, Matthew McHugh from the Center for Health Outcomes and Policy Research, and Raina Merchant, who's an emergency medicine physician and also Director of Transformation and Innovation at Penn Medicine. My work in my K focuses on identifying different combinations of inpatient and ED nursing resources and associations of these combinations, or profiles as I later call them, on patient outcomes and outcome disparities. I'm currently in the second year of this work. So I want to start with a focus on how I'm studying patient outcomes within this context of ED systems of care. When the demand for patient care exceeds resource availability in the hospital, patients board in the emergency department. Boarding is a circumstance where patients are receiving care in the wrong setting for prolonged periods of time, potentially away from specialty care that they could get more accessibly in the inpatient setting. So one example is if you have an orthopedic injury, maybe you need surgery, it's possible that there isn't any availability in the inpatient setting either for surgery or for inpatient management on a specialized ortho unit. And so a patient will stay in the emergency department care and get care by an ED nurse rather than getting care co-located with a specialized specialty team. It's associated with higher odds of mortality, longer patient lengths of stay, and higher hospital costs. One of the first studies I led in my K used the 2016 RN forecast data collected at Penn Nursing and the Center for Health Outcomes and Policy Research and CMS Compare publicly available data on emergency department crowding to study the relationship between nurse staffing and patient boarding times. We found that patients board for 20 minutes less in hospitals where inpatient nurses care for fewer patients at a time. So specifically, we looked at better staffed hospitals, meaning hospitals where med-surg nurses cared for less than 5 patients at a time, compared to less favorable nurse staffing hospitals that were caring for greater than or equal to 5-1 patients at a time. I had the opportunity to learn and apply propensity score weighting to account for confounding in hospital characteristics, which is a common issue in studying this topic, which advanced one of my training goals in learning and applying causal inference techniques to observational data. And the study is important because, once again, where emergency department outcomes are traditionally viewed as just an ER ED problem, we identify that investments in safer inpatient staffing have downstream positive impacts on better patient care in the emergency department. When this patient throughput is advanced in the system, we make emergency department care more accessible to the community and, in turn, hospital care more accessible to our communities. I expanded this work with more contemporary data focused on the reality that there's a behavioral health crisis in emergency departments characterized by long emergency department lengths of stay. This work used data from the 2024 Penn Nurses for All study. We surveyed nurses from hospitals across 10 states and linked that data with, again, the CMS Compare publicly available files. Through a hospital analysis, I looked at nurse staffing inadequacy in the ED and inpatient settings on length of stay for these patients. A 1 standard deviation increase in emergency department and inpatient nurse staffing adequacy was associated with increased ED behavioral health patient length of stay. One potential reason for this is that when nurses care for a manageable workload, they can facilitate patient care processes more quickly. While there may be other factors that are contributing to a behavioral health patient length of stay, like facility availability, nurse staffing adequacy may help nurses advance these processes more effectively, more efficiently, decompress care in the ED, and allow patient throughput to be facilitated. We further identified that in the average study hospital that saw about 64,000 patients a year through the ED, over 3,700 more behavioral health patients could be seen due to just a minor reduction in patient length of stay. This work is being presented at Academy Health in June and informs patient care access for a population in crisis right now in our healthcare system. Next, I want to talk about another outcome that I focused on in my K, which is patient departures against medical advice in the ED. Leaving care against medical advice, also known as a patient discharge, is a marker of care dissatisfaction and untimely care. It's associated with increased patient morbidity and mortality, increased hospital readmissions, and also hospital costs. Again, using data from the Nurses for All study and AHRQ HCUP State Emergency Department database, I led a logistic regression analysis of patients clustered within hospitals and identified that each additional patient added to an ED and medical surgical nurses workload was associated with higher odds of a patient self-discharge in the ED. So increased workloads in the med-surg setting and ED setting was associated with higher odds of patients leaving AMA in the ED. This work will be presented at the Society for Academic Emergency Medicine in 2 weeks. So what is the relevance of this work from a systems and organizational perspective? Well, a common misconception is that if we invest in safe nurse staffing ratios for nurses through a minimum nurse staffing requirement, for example, that's in place in Oregon and California, patients will have to be turned away from care. They'll be denied care because we'll cap the number of patients per nurse. My findings suggest that rather than driving patients away from care, safe nurse staffing may facilitate timely and accessible care for patients. Additionally, there are policies and measures being implemented to measure the crowding of emergency departments or also the capacity of hospitals to see patients. So commonly we think about, do our hospitals have capacity to see patients in our communities? Meaning, do they have enough beds? Do they have enough equipment? Do they have enough medications to see patients? But whether hospitals have enough nurse staffing is often overlooked. And so my findings thus far indicate that this is something that should be considered when we're introducing policies that can assess emergency department and hospital crowding capacity, and also measuring patient quality measures in hospitals. The next focus of my work is optimizing ED systems of care with a focus on patient outcome disparities. Early in my career development award, I was interested in advancing my training goal of acquiring and applying tools to study the conditions of daily living for patients and their health outcomes. I had the opportunity to work with my primary mentor, Dr. Margot Brooks-Carthon, on a qualitative analysis of open text responses from nurses in a large survey from New York and Illinois. This work was funded by an R01, NINR funded R01, so that it was a great opportunity to work alongside my mentor and understand sort of the processes she's doing with her research. We analyzed responses from nurses who wrote about what helps or hinders their ability to provide quality care to vulnerable populations. And as you can read from the quotes here, we identified systemic barriers related to nurses' work environments that hindered nurses' ability to connect patients with high quality care during their hospitalization and afterward. The work was published in JAMA Network Open, and one theme that emerged from the study really piqued my interest, and it was focused on how nurses really experience a lot of moral distress caring for patients with communication barriers, and they really struggle to optimize care outcomes for this population. And so I wanted to study that further. I did a secondary qualitative analysis with my dear colleague, Dr. Kathy Slowinski, who's a pioneer in the area of studying outcomes for patients with experiencing communication barriers. In this study published in Inquiry, we identified that there are interventions like improving language access equipment that should be addressed in hospitals. But most importantly, the systems nurses are operating within must be optimized from an intervention perspective. The quality of nurse working conditions impacts their ability to assess and address care for patients with communication barriers. If nurses are caring for too many patients at a time, for example, we don't want an important care step skipped for this population, like accessing a medical interpreter. Unfortunately, it does happen, even though it is a requirement by law to access this language access service. Just like we don't want to skip reviewing a patient's list of medications when they present for care. So this led us to want to explore further the outcomes of patients with communication barriers from a care perspective and quantitatively. We know from the literature that patients with communication barriers experience challenges accessing care and even higher rates of hospital readmissions and ED revisits. We wanted to look at patient departures against medical advice. Again, this is a marker of untimely care and potentially care dissatisfaction. Using nurse survey data merged with state discharge data from New Jersey, we identified that patients with a preferred language other than English have lower odds of leaving a care encounter against medical advice compared to those whose preferred language is English. This could be due to several factors. It's well established that this population experiences barriers in accessing care, even getting to a hospital encounter or connecting with a primary care provider, for example. It could be that once care is initiated, they are less motivated or less logistically capable of leaving the care encounter and coming back in the future. So that was an interesting finding that we wanted to explore further in the context of nursing systems. Overall, when we've looked at patients leaving AMA, we found that patients are 10% generally more likely to leave AMA in hospitals with inadequate nurse staffing compared to hospitals where nurse staffing is optimized or nurses are caring for fewer patients at a time. Among patients with communication barriers specifically, they experience 13% higher odds of an AMA departure when cared for in a hospital with inadequate nurse staffing. We want to retain all people in care, especially those facing communication barriers. This leads to better outcomes. People deserve the best care possible during care encounters, and it also can reduce hospital costs and avoid readmissions or revisits. The next step in this work is to determine if there are differences in AMA departures among those with and without a preferred language other than English, and how receiving care in hospitals where nursing care is configured in different ways from a staffing and work environment perspective can reduce this suboptimal outcome. Okay, so I want to zoom out a little bit and contextualize what I've discussed so far with you all. I've described how emergency department nursing resources influence ED patient outcomes. I've also described how the inpatient nursing resources influence emergency department patient outcomes. So to improve patient outcomes and reduce disparities in care in the emergency department, we have to improve the systems nurses are configured within. It's not just about focusing on ED care within a silo, which is historically how it's been done. If we have an issue in the emergency department, fix the emergency department. Rather, what I'm showing and what I'm demonstrating with the findings from my Career Development Award is that we have to look at this broader system. And if we want to optimize care in this area, we have to influence both of these areas. There are nursing resources shown here that I've begun to study in each of these settings, like the work environment and staffing configurations and ratios. And there are others that I wish to expand this work upon with, such as skill mix and the presence of nurse practitioners in the inpatient and ED settings. There may be discrepancies in the extent to which there are better or worse investments in inpatient compared to ED nursing resources, or the systems that we're investing in the inpatient and ED side. So I'm really interested in whether there's an association between the concordance or discordance in these resources and patient outcomes. So how I'm doing that, through my training in my K Award, I'm identifying models of care across hospitals by their inpatient and ED nursing resources using machine learning, specifically K-means clustering. Thus far, I've identified through the Penn Nurses for All survey data that there are three typologies when we look at the nurse work environment and inadequate staffing. So here I have in red hospitals, nursing resources that would be considered less favorable from a work environment and staffing perspective. And in green, those that are considered more favorable. And so 3 profiles have emerged thus far. The first on the left shows that relative to the inpatient setting, the ED has less favorable resources. In the middle, both relatively have similar high quality resources. And on the right-hand side, the nursing systems in the setting are less favorable or potentially underinvested in from the inpatient side relative to the ED side. And so next, I'd like to look at associations between these typologies of hospitals and patient outcomes and outcome disparities. And that can give us an idea of where we need to intervene upon within our hospital systems. I want to do a quick overview of other models of care I've been able to analyze and work on with collaborators at Penn Nursing on other funded projects that they have. One study that we published looked at virtual nursing care. Virtual nursing is when nurses augment bedside nursing care by providing care virtually. So they're zooming into a patient encounter to support patient care activities with a bedside nurse. In the Nurses for All study, we analyzed responses from nurses across 10 states who work with virtual nurses, and we found mixed evidence on this model. So first we asked, how much does the use of virtual nurses reduce your workload? What we found is that virtual nursing did not reduce nurses' workload, as you see here in the lighter blue, and in some cases it exacerbated nurse workload. In terms of patient care quality, we found that virtual nursing improved care both a little, and 10% said that it improved quality care for bedside nurses a lot. And so there's mixed findings here. We have future opportunities to expand this work. It's definitely an emerging care model that I'm excited to follow moving forward. A next study that I wanted to highlight has to do with hospital ownership. So across the US, we see that hospital ownership is changing, and many people are wondering, what are the implications for patient care? Well, given how closely nurses work to patients and their influence on patient outcomes, we studied the patient-to-nurse staffing ratio and work environment quality in for-profit compared to not-for-profit hospitals in Illinois. We found that this was an exploratory correlational analysis. We found that the patient-to-nurse staffing ratio in for-profit hospitals was significantly higher compared to not-for-profits, and the work environment was rated less favorably compared to not-for-profit hospitals. Our next step is to expand this work to a 10-state larger scale analysis. A topic that's very close to me as an emergency department nurse who's experienced this before is workplace violence. It's increasing across all hospital work environments. So even as you can see here in our highest quality work environments, close to half and over half of nurses are experiencing frequent workplace violence when we're talking about physical assaults and emotional abuse and verbal assaults, respectively. During my K, I had time to write an R01 proposal that would really identify interventions to address and reduce workplace violence in hospitals through a discrete choice experiment that would really identify the priority interventions that nurses need to improve their safety in healthcare. Hot off the press is a study that we led recently looking at Pennsylvania nurse staffing variation. We found that in orange, nurses provided for us the number of patients they said that they could safely care for in an ideal scenario. And in blue, we charted the observed patient-to-nurse staffing ratios. And what we found was that there is a discrepancy here shown in terms of the number of patients that nurses are caring for at a time compared to the safe level of patients that nurses say they can care for, which is around 4 to 5. And we see wide variation. In the study, Pennsylvania nurses were caring for up to 9 patients at a time, which is a significant patient safety risk. We were also able to determine the costs avoided if Pennsylvania provided a safe staffing ratio in hospitals at a 5-to-1 staffing ratio. Over 550 Pennsylvania nurse departures or nurse turnovers could be avoided, and there would be fewer patient hospital stays. So hospital patient days avoided if hospitals in Pennsylvania invested in safe patient-to-nurse staffing ratios through potentially a policy like a minimum nurse staffing requirement. And these multi-million-dollar cost savings could be reinvested in labor costs and labor investments to reach a safe nurse staffing level in hospitals. This work will be presented at Academy Health in June. An important link that we made in the prior study that I showed was the relationship between retaining nurses in hospitals and patient quality and patient safety. As we've mentioned throughout the talk today, nurses are integral to patient outcomes. They are the most frequent clinician that a patient or family member is going to encounter and interact with in a hospital. And so when we have high turnover in hospitals, that is felt by patients, by families, by communities. what we say in this recent viewpoint published by my colleague Karen Lassiter and I, patient safety begets nurse retention and vice versa. They are two sides of the same coin. So an investment in adequate nurse staffing, an investment in the nursing workforce is an investment in our communities and our public health and our health and acute care settings. I want to just end here with some points about my career development that's been advanced through this award. I've been able to disseminate my research beyond traditional biomedical avenues. I've had the opportunity to publish an op-ed in the Philadelphia Inquirer about the rising workplace violence that we're seeing in the nation's hospitals. I also completed the JAMA Editorial Fellowship, which was an incredible opportunity to see how early career investigators can get involved in biomedical editorial boards. I was co-author on an editorial that was published in JAMA about this topic. And then additionally, I was able to attend training through an NINR funded program at Yale called Nursing Cares, where I learned about the conditions of daily living, how to assess these factors, and integrate that into my own research here with a focus on community-based care. Additionally, was honored to attend the Early-Stage Investigator workshop at NINR, where I had in-person mentorship from leaders at NINR and funded investigators. And additionally had time to write 2 R01 applications during my K to expand the work that I'm finding from my preliminary research. I want to thank my fantastic mentors who have helped me along the way throughout my career trajectory. Thank you all for your leadership and the example you show me. And thank you all for being here today. Happy National Nurses Week. Find me on LinkedIn. And thank you to NINR for this opportunity.
Dr. Muir, congratulations on such an excellent presentation, and really impressed with the impactful work that you shared in such a short time. We're 3 minutes ahead of schedule, and it's really incredible. I know that in reviewing your slides and, all the information, all the work that you've done and doing justice to it. So happy that now we have an opportunity to engage in conversation. As we do that, I just wanted to reintroduce myself to everyone. My name is Rosa Gonzalez-Guarda. I'm a professor here at Duke University School of Nursing, and I have the honor of also co-directing our T32, which is called Nurse Leads, which is focused on nurse-led models of care that advance systems and community and population health. And Dr. Muir, I think that you represent so much of the important work that needs to be done in the areas of systems of care, and really bring to light a lot of the areas of strategic focus of NINR. Obviously, the one around systems of care, but you also touched on some important points around optimizing care for all with the work that you've done with disparities, and the work that you shared also with diversity around the linguistic and cultural needs of patients. And then you also addressed the important work that needs to be done around addressing the conditions of daily living and the opportunities that we have in the emergency department as a gateway for integrating and connecting the healthcare system with those needs and improving population health. So I'm so inspired by your program of research theme that is around generating evidence that improves the timeliness and quality of patient care in community-facing settings, and just want to highlight what a great time this is for you to be doing this work, given the healthcare crisis that we're here in the United States, where we're seeing continuing healthcare rising cost. We're not seeing the outcomes that we want to see with our patients and the populations we care for. And we're also in a nursing crisis, which is not the first time for us, but definitely we're seeing a crisis in nursing staff. And so I think your work is really guiding us in helping us inform some solutions in that area. I also just want to highlight that a couple of weeks ago, the American Academy of Nursing, they had a task force on nurse-led models of care that just published their recommendations. And so much of what you're doing is directly responding for what they're calling our entire nursing community to respond to really think about what novel nurse-led models of care look like. And I want to commend you also for leaning in to generating the evidence of doing that, sharing that evidence broadly through the work that you've done in the conferences and the publications, the op-eds that you're doing, and leaning into that. And then also thinking about and starting to explore the cost and how you can help, restrict or minimize, reduce the cost within this context of improving care. So I will stop with those summary points just to say I am in awe of your work, and I'm so excited that I have this wonderful privilege and honor of being here with you today to guide us through some Q&A. So I'll just start off with a question that I have, and as I do that, I hope the audience joins in. Kudos to everyone that's here, and also happy Nurses Week to all of you. If you can just please share your questions, staff is going to help collate that and feed them to me so we can get to as many questions as possible. So in the spirit of Nurses Week, I just want to step in and honor your nursing lens and ask you if you could share a little bit more about how your clinical experience as a nurse, you talked a little bit about that, uniquely shapes the lens that you use in your research. So that's the first part of the question. And how that research that's being led by you is you're hoping will have a clinical impact.
Well, first, thank you, Dr. Gonzalez-Guarda, for that amazing overview and for being my moderator here today. It's a true honor given the incredible program of research that you lead. So thank you for that. My lens, as I said previously, is informed by working in community health settings. As a nurse, nurses see things that others don't see, and we're in all spaces, and we are incredibly innovative and creative in terms of solutions. And so we're well positioned to identify research problems and then triangulate what types of interventions need to be integrated. My research was really motivated by working as an emergency department nurse. And I remember working with patients who traveled hours to come to emergency departments because that was the only place where they could get care. Maybe they were afraid of receiving care in other care settings, or they didn't simply know how to navigate getting an outpatient primary care visit set up. And so it's essentially an emergency department visit where you have a touch point with a registered nurse who can facilitate that next transition or get the patient admitted to the hospital. And so I really wanted to, a lot of people don't think of the emergency department as a community-based setting, but it most certainly is when you think about how its proximity is to communities and the small windows of time that nurses have to make a difference, to bring a patient to safety if they're having a domestic challenge or issue or illness that has happened, among other factors. I think that in the context of my research, nursing has been overlooked as a potential lever to improve the outcomes that I'm focusing on. So hospital readmissions, ED revisits, all things that we want to make our systems more lean, right? We want to reduce healthcare costs, both for the health system and for payers and for patients. And so there's a lot of things that have been proposed in the emergency department setting that nurses for the most part, end up implementing. Like an example is reconfiguring the flow of patients through an emergency department. Well, you have to have enough nurses to do that. A lot of studies look at, do we have enough beds in hospitals to see patients? Well, most importantly, we have to have enough nurses, staff to see patients in those beds to facilitate adequate care. And so my point is that nurses have really been overlooked in this setting as a potential intervention point. And my lens from a clinical practice perspective really informs that, knowing how nurses can make a change in that small window of time.
Thank you. Thank you for answering that. I think there's a question in here that is very much aligned with this point that you're making. And please keep the questions coming. I'm seeing them show up. We have a question here that says, what nursing surveillance indicators during the emergency department admissions predict deterioration in medical surgical inpatients?
That's an interesting question. I think that it's honestly been, when I think of nursing surveillance, I think that this this is an area of study that's been under investigated in, I think, because the ED, as I said, is such a unique setting. There's a lot of complex and chaotic cultural factors that are happening in the ED, as opposed to like in the ICU, where predictive tools have been developed because patients there are consistently on cardiac monitors. That's not the case in emergency departments, where we often don't know that a patient needs continuous cardiac monitoring until labs or diagnostics come back. But I think that where that isn't present in the ED, there are certain things that can be studied, like the extent to which nurses are able to complete all of the tasks that they need to for patients. I think I mentioned earlier in my study, like when you do a huddle, which some people, my colleague Karen Lester calls it a vibe check in the huddle, if you can look around and know that you don't have, staffing is a little bit thin today, you're thinking, okay, I might not be able to get to those would be nice things for patients. I'm going to have to do the bare minimum, administer the medications, turn the patient, get the patient walking, perhaps not do all of the things that I can because I'm overextended caring for too many patients at a time. So perhaps a proxy for a type of nursing surveillance in the ED is whether or not nurses are missing care, missing optimal or the ideal care measures that they need to for patients in that setting. And I think that's an interesting idea to look at how it predicts deterioration later on when patients are admitted, because as you know, I assume the person asking this question, there are important care bundles that are initiated in the ED, sepsis, stroke, AMI. And so if nurses are not getting the two blood cultures from two different extremities, if they're not getting the patient to the CT scan within 15 minutes, like these are all things that we could study from an EHR perspective and later chart that out from a prediction perspective when the patient's in the ICU, or maybe they went to the med-surg unit and then decline and have to be transferred to the ICU. I'm thinking of Dr. Cato's and Rossetti's CONCERN trial. These are things that, there are opportunities to expand the research in that area, especially with the development of AI and how it's it's going to help us study settings that have historically been hard to examine, like the ED.
Right. And I commend you for leaning into that and integrating novel technologies in the work that you're doing. Was very interesting to see the study that you did on virtual care nursing and what that is doing and the potential for the future. So I don't know if you want to share any more about that work.
Sure. Virtual nursing is really interesting to study. There's a lot of mixed thoughts on this new care model. And I think that's exciting. I think we need to lean into uncertainty. And when there's uncertainty, we need to lean into empirical investigation and study it more and lean in more and listen to what nurses have to say. So when I say that nurses see things that others don't see, like when there is any type of change in healthcare, you want to talk to the nurses about how that change is going, because the nurses are receiving whatever that new intervention or technology change is, and they are implementing it, tinkering it on it, taking notes. They have feedback if you just ask them. And that is the case with virtual nursing. I think it's been introduced probably before we have a lot of evidence about it. Before we did this virtual nursing study, there were less than 5, definitely less than 10 studies that have been done on virtual nursing, no trials on virtual nursing. And so our study was observational from a study design perspective, but it was important to talk to nurses who had worked with these virtual nurses, because when we think about optimizing nursing care and the systems that they operate in, we want to optimize those systems because in many cases, it can be a difference of life and death for a patient. Whether a nurse is like in a patient's room when they have a cardiac arrest, or they're attending to multiple patients and not even in that room. We do have to think about these things as simple as like a virtual nursing model, which is exciting because it could decompress nurses' workload and provide more resources for nurses to attend to their patients. Thus far, like, we need to do more exploration, because some nurses are saying it's really helpful in this case and it's really not helpful in this other case. It actually can make my workload worse because I'm having to respond to more call bells. We know that there's this study of alarm fatigue that nurses experience, but there could be promise from a patient care quality perspective and from a technology perspective as well. Patients, I think one of the quotes from our qualitative study of this was patients thought it was a TV and were trying to turn it off with a remote, which is kind of funny. So there may be some patient education that we have to do from a technology perspective. So more to come in this area. That I think it's exciting, but first and foremost, we have to make sure that it's not exacerbating nurses' workloads, because historically nurses, it's sort of been a knee-jerk reaction to give more to the nurse, when really, if we want to put more on a nurse's plate, we need to take a bit off so that nurses can provide the best care possible to patients. Thank you for asking about that topic.
Yeah, there's a couple questions here that I think are under this theme that you introduced to us and highlighted around the environment and the influence on nursing and therefore the patient outcomes, right? And so one of the main strains that we're seeing is, closing of hospitals, particularly in rural settings, and closing, like for example, there's a question around OB units closing and what additional strain that might be having on the emergency departments. Can you speak a little bit towards that sort of system strain that is driving the impact on the ED?
Yeah, that's a really excellent question. And I think it makes addressing emergency department care even more of a priority. Right. Because I think what the person posing the question is getting at is, if we are seeing hospital closures, I'm from Virginia and I'm thinking of Southwest Virginia. This is a historically rural part of the country. It's Appalachia. Their closest hospital, their like probably level 1 trauma center is Roanoke Carilion. If these smaller community hospitals close, you're driving more patients to Roanoke Carilion or UVA or Northern Virginia. We are basically driving more patients into emergency departments where we already are experiencing a crowding crisis. If we already are struggling to see patients in a timely manner, and by the way, timely care is also associated with safe care and high quality care, this is a problem. And emergency departments have historically been that consistent safety net. They're open 24/7. And they offer care services that are accessible compared to other settings. And so that is a significant concern in our rural areas. And I think it's going to involve a lot of coordinating within states in terms of how they're organizing important resources like nursing care, as well as other types of resources, because yes.
Thank you. So you're extraordinary in terms of what your trajectory has been and the impact that you've done in such a fast time. And you've been able to take advantage of so many training opportunities, a lot of them supported by NINR, and I know you're very grateful for those. Can you talk a little bit about, since this is the inaugural Early Stage Investigator lecture, and you're the perfect person to kick us off here, can you talk to us a little bit about how you benefited from those training opportunities and what recommendations you have for early stage investigators here in the audience?
Certainly, that's a great question. So I was trained on an NINR T32 through my postdoc. And if it weren't for that postdoc, I wouldn't have been able to make sort of a hard pivot into the work that I'm doing now. So I was able to get specific training in health services, health policy, the systems, optimizing systems type research when I came to Penn for my postdoc and pursued this T32 that was funded by NINR. There was a lot of, as we say, fangirling over people who I admired in this field who were NINR funded, that when I had that opportunity, it was just outstanding to receive training on how you do the methods, how you would, simple things like developing surveys, how to come up with, high quality questions, how to do rigorous statistical analyses on that type of data. One of my favorite aspects of this work is disseminating work beyond scientific walls and moving beyond to policy, moving on to talk to people who are actually going to make this change, talking about the academic hospital connection that we were discussing before this call, meeting with hospital leaders, meeting with nurses to say, like, here's what we found in this data. Is this actually what you're experiencing? Just like the virtual nursing. Here's what we wrote about. Is this what you're seeing in the clinical setting? If not, let's go back to the drawing board. Let's figure out, you know, take that lens, figure out how to ask the question better, figure out what we need to look at next. That's been a tremendous benefit of getting trained specifically at Penn, Chopper, in the T32. And then advice that I would say to others is, you know, general advice I give is lean into the thing that you're good at, into the thing that you're passionate about, because I think that that's, you know, baseline and important quality. Aside from that, paying attention to, I think we need to be paying attention to what issues are most pressing right now in our healthcare system. Like an example is rural health. I'm very concerned about rural health from a community health perspective, from a hospital access perspective, paying attention to these crucial societal issues, because I promise you, nurses are integral to nurses, like, the road always leads back to a nurse somehow with a lot of these pressing healthcare issues in our country. So sort of pay attention to what these pressing societal issues are, and really look at your lens as a nurse, or understand how the nursing lens can influence that and move the needle and address solutions in that area. I think working towards that goal as an ED researcher, it's been sort of understudied. Fixing some of these ED issues have been understudied because it seemed kind of impossible. And I think coming in with a nursing lens, I see how we can make some movement on this issue. And I know that other nursing researchers in an early stage can do that.
Thank you. Thank you. I think we have 1 minute before we turn it over to Dr. Ackland. So if you want to just, you know, wrap us up with telling us what's next for you.
What's next for me is I'm really excited to gain momentum on this issue of emergency department crowding and boarding. I'm really excited to present my findings from my K at Academy Health, because it's one of the first times that nursing has been introduced as a potential solution to address this issue that I'm super passionate about. On a broader scale, expanding my work, I'm very excited to address workplace violence, because I'm really concerned about that in healthcare, and continuing to learn from greats like yourself, Dr. Gonzalez, and other within the nursing network. So thanks.
Thank you. Thank you, Dr. Muir. Thank you for your incredible work, for everything you shared with us today. And we'll hand it over to Dr. Ackland, who's going to wrap it up. Thank you.
Well, thank you so much, Dr. Gonzalez-Guarda. I couldn't have said it better in terms of just having the opportunity to hear from you, Dr. Muir. It has been amazing to hear about your trajectory and what you're doing with all of the tools that you had in front of you, and really taking advantage of the mentors who have helped to guide you along the way. I'm sure they're very proud. We're very proud of you as well. And with that, I'm going to go ahead and wrap us up. I believe coming up on the screen is there should be a QR code. We're switching over. Okay. Just a quick reminder, we do have continuing education credits that are available for today's session. Please use the QR code on the screen to complete the evaluation and to receive your certificate. We'll also share the link in the chat. It should be popping up if it hasn't already. And we'd like to thank the Foundation for the Advanced Education in the Sciences for their support in providing the evaluations and the continuing education credits. Next slide, please. And one last time, I would really like to close by thanking Dr. Muir and Dr. Gonzalez-Guarda for sharing their work and their insights with us today. And more broadly, thank you to the entire nursing community. As a reminder of Nurses Week, our scientists, clinicians, trainees, educators, and partners. We're just very proud to have you to be part of our journey as well. You truly are powerful, as your contributions are essential to advancing both the science and the practice. So thank you to everyone who joined us today.